Welcome to Critical Care Simplified. Today, we're focusing on diabetic ketoacidosis, or DKA, how to recognize it, understand what is happening physiologically, monitor the patient, intervene safely, and escalate when treatment complications appear. If you are new to the ICU, this is bedside knowledge you need. In DKA, timely identification can mean the difference between rapid recovery and life-threatening complications. Nurses are often the first to notice a subtle change in breathing, mentation, hemodynamics, or laboratory trends. Your job is to connect those findings early, communicate clearly, and act within the treatment plan. Start with the history. Ask about missed insulin doses, medication access, recent infection or illness, and new onset diabetes. Also consider alcohol or drug use, recent trauma or surgery, and comorbid heart or renal disease. These factors can trigger DKA or make its management more complex. At the bedside, classic findings include polyuria, polydipsia, nausea, vomiting, abdominal pain, dehydration, and altered mental status. Look for dry mucous membranes, poor skin turgor, deep and rapid Kussmaul respirations, and a fruity odor on the breath. The patient often looks visibly ill. Do not rely on marked hyperglycemia alone. Euglycemic DKA may occur with only mildly elevated or even normal glucose, especially in patients taking SGLT2 inhibitors. DKA may also present mainly as confusion, agitation, coma, nausea, vomiting, or abdominal pain, and it can coexist with sepsis or myocardial infarction. Clinical findings raise suspicion, but laboratory confirmation is essential. The source criteria include glucose above 250 milligrams per deciliter, although it may be lower in euglycemic DKA, positive serum or urine ketones, arterial pH below 7.3, bicarbonate below 18, an elevated anion gap, and electrolyte abnormalities, especially potassium. Now, connect the signs to the physiology. Insulin normally allows glucose to enter cells and provide energy. When insulin is absent or insufficient, glucose remains in the bloodstream while cells turn to alternative fuel sources. At the same time, glucagon, cortisol, catecholamines, and growth hormone intensify the metabolic crisis. The liver releases more glucose while cellular uptake falls, so blood glucose rises. The body then breaks down fat. Fatty acids are converted into ketone bodies, and those ketones accumulate and cause metabolic acidosis. High glucose drives fluid loss and dehydration. That sequence creates the DKA crisis. Hyperglycemia causes excessive urination and dehydration. Acidosis produces deep, rapid Kussmaul breathing as the body tries to compensate. Acidosis and dehydration can impair brain function, causing confusion, lethargy, or coma. Potassium may appear high on admission because acidosis shifts it out of cells even though total body potassium is depleted. Monitor blood pressure, heart rate, respiratory rate and pattern, temperature, and neurological status closely. Hypotension and tachycardia may signal hypovolemia or shock. Fever may point to infection. Increasing respiratory fatigue or shallow breathing is concerning. New confusion, agitation, or decreased responsiveness requires immediate assessment and escalation. Trend glucose, potassium, acid-base status, bicarbonate, the anion gap, sodium, and phosphate. Do not focus on a single result. Potassium may fall quickly after insulin begins. A rising anion gap or persistently low bicarbonate suggests continuing acidosis. The goal is controlled improvement, not abrupt correction. Use strict intake and output charting. Document all administered fluids and all output, including urine, emesis, and drains. Monitor urine volume and characteristics hourly. Low output may reflect ongoing hypovolemia or renal impairment. Also assess continuing losses and watch for edema, lung crackles, or rapid weight gain. The first treatment priority is restoration of circulating volume. Assess hydration and hemodynamics, then begin the ordered isotonic saline resuscitation. The course describes an initial 0.9% sodium chloride bolus of 15 to 20 milliliters per kilogram over the first 1 to 2 hours, followed by reassessment and individualized adjustment. Reassess blood pressure, heart rate, urine output, clinical response, and ongoing losses. As the patient stabilizes, fluids transition toward maintenance based on corrected sodium, glucose, and clinical status. Use extra caution in pediatric patients, older adults, and people with cardiac or renal impairment because fluid requirements and complication risks differ. Insulin suppresses ketone production, lowers glucose, and helps correct acidosis, but it begins only after initial fluid resuscitation has started and potassium is confirmed above 3.3 milliequivalents per liter. The course describes regular insulin as a continuous IV infusion at 0.1 unit per kilogram per hour, without an initial bolus in most adult cases. Check glucose every hour and follow ketones, bicarbonate, pH, and the anion gap. The source goal is a gradual glucose decrease of 50 to 75 milligrams per deciliter per hour. If glucose falls too quickly or below 200, dextrose is added to IV fluids and the insulin rate is reduced while ketosis continues to clear. Potassium is a safety priority because insulin drives it into cells. If potassium falls below 3.3, insulin is paused and potassium is replaced. The course also calls for monitoring phosphate, magnesium, and sodium. Replacement is individualized, with ECG monitoring when potassium shifts create arrhythmia risk. Transition from acute therapy only when the anion gap has closed, acidosis has resolved, vital signs are stable, potassium is stable, and oral intake is tolerated. When moving from IV to subcutaneous insulin, overlap the two by 1 to 2 hours to prevent rebound hyperglycemia. Continue electrolyte monitoring and patient education. During treatment, stay alert for 4 major complications: hypoglycemia, hypokalemia, cerebral edema, and fluid overload. These may develop quickly, and the earliest clues are often visible at the bedside or in a trend. Prevention depends on controlled correction, frequent reassessment, and rapid communication. Sweating, shakiness, tremors, irritability, or confusion may signal hypoglycemia. Check glucose immediately and follow the ordered dextrose response. Muscle cramps, weakness, palpitations, ECG changes, or arrhythmias may signal hypokalemia. If potassium is dangerously low during insulin therapy, hold insulin, replace potassium, and monitor cardiac rhythm closely. Cerebral edema is rare but devastating and is most common in children and adolescents. Watch for headache, irritability, decreased level of consciousness, altered mentation, new bradycardia, or hypertension. If suspected, stop fluids, elevate the head of the bed, and urgently notify the provider or rapid response team. Fluid overload is more likely in older adults and patients with heart or renal failure. New edema, crackles, rising jugular venous pressure, Rising blood pressure or shortness of breath should prompt immediate reassessment. Slow or stop fluids as appropriate within the care plan. Assess respiratory status and notify the provider. Identify the complication promptly. Stop or adjust the likely causative therapy. Implement the targeted intervention. Reassess the patient and repeat monitoring. Then document and escalate. If the patient does not improve, deteriorates rapidly, or develops life-threatening signs, activate the appropriate emergency response. Here is a concise SBAR example. Situation: I'm calling about the DKA patient in ICU bed 4 who has developed new confusion and a rapidly falling potassium level during insulin therapy. Background: the patient is receiving fluids and a regular insulin infusion, and the anion gap remains open. Assessment: the patient's neurological status has changed, and the potassium trend creates immediate risk for hypokalemia and arrhythmia. I have repeated the assessment, checked the latest glucose and labs, and placed the patient on close cardiac monitoring. Recommendation: please evaluate now and provide orders for treatment adjustment and repeat monitoring. Remember 5 points. 1. Recognize both classic and atypical DKA. 2. Connect insulin deficiency to hyperglycemia, ketosis, acidosis, and dehydration. 3. Monitor trends, especially neurological status and potassium. 4. Fluids come first, then insulin with potassium safeguards. 5. Complications demand immediate reassessment, targeted action, documentation, and clear escalation. DKA management is a team effort, and vigilant nursing assessment can prevent a complication from becoming a crisis. Use your unit protocol, communicate changes early, and keep asking what the patient's trends are telling you. Thank you for learning with Critical Care Simplified.